if you went to the epineuritis, okay, you need to write like 9, 8, or 10 words. You need to say, oh, this is the epineuritis of both the external abdominal oblique and the internal abdominal oblique. So it is better for you just to put 2 words, right? External lamina of rectus sheath. You good? What is this here? Superficial inguinal ring. Now, what is this here? Vaginal process is a female. This looks like a female? This is the vaginal tunic. This is the spermatic cord. What's this muscle here? Cremaster muscle. What's this muscle here? Cremaster muscle. It is coming from where? The cremaster muscle. It's coming from the internal abdominal oblique. No problem. Okay, the cremaster muscle is coming from the internal abdominal oblique. Now, when we tag things here, okay, take a minute. We may tag the cremaster muscle by itself, or we may be tagging what? The spermatic cord. These are 2 different structures. Okay, so take a minute and see exactly what we are tagging. If you are tagging the muscle, it is what? Cremaster muscle. If we ask you about the origin of this muscle, it has to be what? Internal abdominal oblique. If you ask about the spermatic cord, that is the spermatic cord. And we said what is the components of the spermatic cords? Vas deferens, testicular, and lymphatic, right? The vas deferens and the vas deferens artery and the vas deferens nerve and the vas deferens lymphatic. Only the things that are going where are going to the testes. Okay? Again. What is this here?
Rectus
No, this.
Rectus abdominis.
Rectus abdominis muscle. What is this here? External lamina of rectus sheath. Now, let us see a couple of words regarding the innervation of the abdominal wall. The nerve that we're going to mention, this nerve runs through all the abdominal muscles. They run through the transverse abdominis muscle, the internal abdominal oblique, external abdominal oblique, all the way to the skin outside. Okay? It is the same muscle. Okay? Don't worry about their branches. Now, you remember the spinal nerves? The ventral branch of T13, okay, runs just caudal to the last rib, which is the floating rib, right? T13 runs just caudal to it. Okay? Now, L1 and L2, they gave them look like fancy names. Okay? They call L1 as the cranial iliohypogastric. L2 is the caudal iliohypogastric. And then the third one is the ilioinguinal. So, the major nerve that innervates the abdominal wall is T13, cranial iliohypogastric, caudal iliohypogastric, and ilioinguinal. Okay? The easiest way to find them, they run very clearly on the wall of the transverse abdominis muscle. So what muscle is this? Okay, and this nerve, if you want to tag them, we have to tag them on the wall of the transverse abdominis muscle. We can't tag them anywhere else. Okay? Again, this is the last rib. This is T13. Because the last rib is the rib number 13, right? So, this one is T13. This one is the cranial iliohypogastric. This one is the caudal iliohypogastric. This one here is the ilioinguinal. These are the nerve that innervates the abdominal wall. And you have the understanding, they innervate all the abdominal muscle, the transverse, the internal, and the external, all the way to the skin. As simple as that. Okay? Now, when you cut the skin, you can cut part of this nerve? Yes. Is that a big problem? No. Why? Because these nerves, they will distribute like that. So even when you make your cut, okay, you're gonna cut what? 1 or 2 of them. It's still, okay, there is another 10 on the same area. Because they branch out. So when you make your cut, literally you're gonna cut 1 or 2 of these, but it's not a big deal. Because it's still, there is a bunch of nerves from the same nerve innervating the whole area. Make sense? So while you are doing your cut, okay, you're not gonna be trying to avoid these nerves. There is no way to avoid them. Okay, because they distribute all over the area. Okay? So you make your cut, you're gonna cut a few of them, but it's not a big deal at all. You good? Like nothing is gonna happen. Now, this in terms of the abdominal wall nerve supply or innervation. T13, cranial iliohypogastric, caudal iliohypogastric, and ilioinguinal nerve. You need to know the innervation of the abdominal wall. We will ask you about that in the lecture. We will ask you about that in the lab. These nerves, they run on the lateral, on what? On the transverse abdominis muscle. If we want to tag them, we have to tag them there. There is no way we can tag them anywhere else. Make sense? So you go to your specimens, you go to the transverse abdominis muscle, and you identify these nerves. Their function is to do what? To innervate the abdominal wall. When we say abdominal wall, all the layers that we have been talking about. Make sense? Clinical significance, they don't have a clinical significance. So if you ask about them, we'll ask about their function. Good?
Mm-hmm.
Now, Dr. Rajab covers this or not? I can't remember. I was there in the lecture, but I can't remember.
Literally same.
Does he cover when you cut through the abdominal wall? There is difference in the layers in the cranial part of the abdomen to the caudal part. He covered that part? Or no? No. I mean the layers. Okay.
No, literally.
Let me.
The abdominal layers.
Okay.
Because why are you not?
I want you to understand this. Okay. So when you go to surgery, you shine. How is that? Okay.
Sounds good.
It will add a little bit to your information. Okay. Now, let me orient you. Okay. This is the linea alba here. This is the rectus abdominis. Okay. This is here is the rectus abdominis muscle. You know what? I'm gonna skip on this. Okay.
Okay.
Let me check. if I realize that he covered it, I will come back to it. Okay, let me skip to the blood supply. Now, this is the abdominal aorta. The abdominal wall blood supply is from 4 major arteries. How many arteries? 4 of them. You need to know them. Okay? Now, this is T13. And you're gonna dissect this artery. They call this the common trunk for the cranial, abdominal, and the caudal phrenic. We said every time you see the term phrenic, it has to go where? To the diaphragm. So this is a common trunk, and it will give 2 branches. One that go to the diaphragm. We call that the caudal phrenic because it is approaching the diaphragm from the caudal aspect. And the other one is what? The cranial abdominal. This supplies what? The cranial dorsal aspect of the abdominal wall from the cranial abdominal artery. The cranial dorsal abdominal wall supplied by the cranial abdomen. Now, the caudal-dorsal abdominal wall is supplied by deep circumflex iliac artery, which is this one here. Deep circumflex iliac artery. We have dorsocranial part of the abdominal wall and caudodorsal part of the abdominal wall. The cranial part supplied by the cranial abdominal artery. The caudodorsal part supplied by the deep circumflex iliac artery. You need to see these arteries in your cadavers. We'll ask you about that. Why? Because this is the blood supply for the abdominal wall. You need to be aware of it. We'll ask you about it in the lecture. Also, we'll ask you about it in the lecture. So you need to make sure that you see. Very easy to find. So the craniodorsal part of the abdomen or the abdominal wall supplied by the cranial abdominal artery. The caudodorsal part of the abdominal wall supplied by the deep circumflex iliac artery.
You said it was the caudal dorsal aspect?
Yeah, all this area here.
Okay.
So we're done with the dorsal part, right? Now, let us go to the ventral part. And the ventral part, that is where you do your incisions, right? Now, let me refresh your memory.
Bless you.
Thank you. Now, what artery is this? The ventral aspect of the thoracic cavity. This is the internal thoracic, right? The internal thoracic will give this branch, which is the cranial epigastric. The cranial epigastric will go through the rectus abdominis muscle to run as the cranial superficial epigastric. Internal thoracic artery. One of the terminal branches is the cranial epigastric. The cranial epigastric is running on the dorsal aspect of the rectus abdominis. Okay? Then it will go through the rectus abdominis to run on the outside as a subcutaneous tissue. Now we don't call it cranial epigastric, we call it what? Cranial superficial epigastric. And this will supply the cranioventral area of the abdominal wall. So it is the cranial superficial epigastric which is the continuation of the cranial epigastric, which is coming from the internal thoracic. As simple as that. Okay? Now, the interesting story is here, on the caudoventral part. And that is where you do your incisions. Okay, so focus with me on this. All those are very straightforward, right? Cranial abdominal, deep circumflex iliac, cranial superficial epigastric, right? Now, this one here is the caudal superficial epigastric. And the caudal superficial epigastric will run cranially, the cranial superficial epigastric runs caudally, and the anastomose in the middle here. Anastomose means what? They interconnect. Okay, they supply the same area. Now, here we have seen that the cranial superficial epigastric is a continuation of what? Of the cranial epigastric. The cranial epigastric, when it gets to the outside, we call it cranial superficial epigastric, right? The story is a little bit different on the caudal aspect. Okay, now, through the superficial inguinal ring, the external pudendal artery will come out through the superficial inguinal ring. Okay, now, the external pudendal will give two major branches. The largest one is the caudal superficial epigastric. It looks like a cranial continuation of the external pudendal. Okay, because the external pudendal we're going to give another branch. Okay, that goes to the scrotum and to the vulva in the female. Okay, but let us focus on this one. This is the caudal superficial epigastric. This runs ventral to the rectus abdominis muscle. Okay, so the caudal superficial epigastric is coming from the external pudendal. So it is not a continuation of the caudal epigastric, because the caudal epigastric is a completely different artery, okay, that runs on the dorsal aspect of the rectus abdominis muscle. While the caudal superficial epigastric is the major branch of what? Of the external pudendal that comes out from the superficial inguinal ring. So pay attention where we are tagging this. If we tag here at the level of the superficial inguinal ring, it is what? It is the external pudendal. Okay? If we tag it ventral to the rectus abdominis at this level here, now it is what? The caudal superficial epigastric. So the caudal superficial epigastric is a branch of the external pudendal. The cranial superficial epigastric is the continuation of the cranial epigastric. Make sense? Now, the caudal epigastric is the branch by itself. It runs on the dorsal aspect of what? Of the rectus abdominis. So you pay attention. If we tag an artery dorsal to the rectus abdominis, it will going to be what? The caudal epigastric. Okay? If we tag the artery coming out of the superficial inguinal ring, it will going to be what? External pudendal. If we tag it on the ventral aspect of the rectus abdominis, it will going to be what? Caudal superficial epigastric. Yes?
Is the caudal superficial part of the four major branches that supply the abdominal wall?
Yeah, it supplies the caudoventral aspect of the abdominal wall.
So are there more than four major branches?
Okay? So we have cranial abdominal, we have deep circumflex iliac artery, we have cranial superficial epigastric, we have the caudal superficial epigastric. The caudal epigastric is supplying the what? The dorsal aspect of the rectus abdominis. Remember, when you make your cut through where? Through the linea alba. The cranial epigastric is to the side of that. Okay, so you're not gonna run any chances of cutting that. Yes?
Which artery
the cranial superficial epigastric, and anastomosis with the caudal superficial epigastric. The only main difference here I want you to be aware of is that is the caudal superficial epigastric is the branch of the external pudenda, while the cranial superficial epigastric is the continuation of the cranial epigastric. Make sense? Now let us see them. Okay, which one is this?
The caudals.
Okay, wait. Take a minute and orient yourself, okay? Let's start with this one. Okay? This is the prepuce here, is being reflected. Okay? This is the
Rectus abdominis.
rectus abdominis. Okay, this is the external lamina of the rectus sheath. Okay. Which artery is this?
The caudal.
At this level here it is what? This is the spermatic cord. At this level here it is what?
External pudenda.
External pudenda. Here it is what? Caudal superficial epigastric. Okay, because it is running on the ventral aspect of the rectus abdominis, right? It is just, they reflex this and they pull it down. But if you put the skin back, this artery here is running here, right? So this one is what? Caudal superficial epigastric, right? Now, okay, let us come to this one here. Okay, this is the rectus abdominis here. Remember we said the internal lamina of the rectus sheath is coming from which muscle? Transverse abdominis. So this is the transverse abdominis. This is the internal lamina of the rectus sheath. This is the rectus abdominis muscle. So which artery is this? Caudal epigastric. So this one is the caudal epigastric. This one is what? Caudal superficial epigastric. You get the difference? Very simple like that. So just pay attention, okay, where we are tagging it. Yes? I will repeat. Okay? Now, this is the rectus abdominis muscle. Here, okay, this is the external lamina of the rectus abdominis, which is formed by the epineuritis of the external abdominal oblique and the internal abdominal oblique. Okay? And this artery will run here, ventral to the rectus abdominis. This is the caudal superficial epigastric artery. Now, in this one here, they remove the rectus abdominis muscle. And here you can see the epineuritis of the transverse abdominis. And we said the epineuritis of the transverse abdominis will form the internal lamina of the rectus sheath. And the artery that runs on the dorsal aspect of the rectus abdominis is what? The caudal epigastric. Again, if you come here, this is the caudal epigastric. This one here is what? The caudal superficial epigastric. Make sense? Now, which nerve is this?
T13.
T13. Which one is this? Cranial. Iliohypogastric. This one,
Caudal.
caudal iliohypogastric. And that one there is the iliohypogastric. Now, which one is this?
Caudal.
And which one is this?
It's the same thing, isn't it?
It is the same thing, right? The only difference, this is the ventral branch and this is what? So which one we tag, don't freak out. Okay, it is the same one, right? Freak out. You good? This is just the same thing that we have, okay, we have said. Again, this is a male or a female?
A male.
Right, okay, to the far left.
This is the same one. Just we take this one and we make it big. So this is a male or a female?
Female.
This is a female, because this is what?
process.
This is the vaginal process, right? Now, what is this here?
Superficial.
Superficial inguinal ring. What is this here?
Vaginal.
Vaginal process. What is this here?
The ligament.
What we call it?
Round ligament of uterus.
No. The round ligament inside here. Okay. This is here, is this part here. You remember we said the epineuritis of the external abdominal oblique, this is the linea alba. Okay, we said the epineuritis will divide into abdominal insertion and a pelvic insertion. And we said the most caudal part of the pelvic tendon is what? Is the inguinal ligament. So this part here is the inguinal ligament. Okay, this is the epineuritis of the external abdominal oblique. This is the superficial inguinal ring. Okay, this is space here. This is the femoral artery and vein. Okay, this is space here is what? The vascular laguna. This is the inguinal ligament. This is the superficial inguinal ring. This is the vaginal process. It consists of what? The round ligament of the uterus with some fat. Okay? What is the clinical significance of this?
Inguinal herniated.
Predisposed females to what?
I'm sorry.
Yes.
Is that like due to space or is it just because it's female?
Because it's a female, you have a natural space and you have an structure that is coming from the uterus sitting there. So it predisposes the female to inguinal hernia. Now, have you ever seen this term like paracentesis? Which means abdominocentesis. It is the same. Okay, you can say either paracentesis or abdominocentesis. And here you just withdraw peritoneal fluid. Okay? Now, if you want to do this, you will do it on the caudolateral aspect of the umbilicus. You need to find the linea alba, and you need to find the umbilicus, and then you go caudolateral to that to insert your needle. Why you do that? You need to avoid the falciform ligament, and also you need to avoid the bladder. Okay, so you find the umbilicus and you go caudolateral to that. Because on the dorsal aspect of the linea alba there is what? The falciform ligament. And at the top of the falciform ligament, all the way to the liver, that is the round ligament of the liver, right? And that used to be what in the embryo? It used to be the umbilical vein. Okay, so, and the falciform ligament is full of fat. So if you insert the needle there, you will withdraw nothing. Okay, nothing will come out with you. That's why you need to avoid it. Not because if you hit it, something is going to happen. Nothing is going to happen. It's full of fat. But you're not going to be able to obtain any peritoneal fluid. Okay? So you go caudolateral to that. Because the bladder, when it is extended, it gets very close to the level of the umbilicus. So you go caudolateral to that. By doing that, you'll be avoiding a bladder, especially if it is full, and also you're going to be avoiding what? The falciform ligament, because it is full of fat, you're not going to be able to obtain any fluid. Make sense? So, if you put a needle there, and we ask you what is the purpose of this needle, you look at your landmark. If it is caudolateral to the umbilicus, that needle is supposed to be for what? Not intramuscular injection. It's going to be for what? Paracentesis. If I told you that I insert this needle here for paracentesis, is this the right area or the wrong area? And you need to tell me, still you go to your landmarks, you go to the linea alba, you go to the umbilicus, and you see where is the needle is. If it is caudolateral, then it is what? Is the correct. Okay? If it is not, then it is not, right? Okay? If it is too caudal, I will run the possibility of hitting what?
Bladder.
Is that a problem? What?
Yeah, urine instead.
Why that? What's wrong with that?
Sepsis.
That deep for me. Give me simple explanation. Everything you said is correct. Okay? You have urine in the abdomen, you have peritonitis, right? You have peritonitis, God help you. Right? Good?
Question,
Yes, ma'am.
so, for giggles, if you were to put the
Oh, it's funny.
syringe needle more medial versus lateral, would that be, like if you were to put it on the lamina,
It's wrong.
wrong, okay. And can you see the falciform ligament in our,
No. You have seen it in your cadavers, right?
that's what I'm asking.
But you know, that's why we do the anatomy, guys. It's like, I want you to do that link, okay? You are dealing with intact animal, okay? But you know what is inside, in every area. Because you are not dealing with a dissected animal, you are dealing with a completely intact animal. Okay? But because you did the dissection, you know the location of every structure and every organ. And that's why you need to do an anatomy. Make sense? Yes. Okay. If you want to insert the needle, you have to do it here or here.
One more question. And the falciform ligament, it's the structure that runs on the abdominal wall that will connect to the liver?
Yes.
Okay.
And that is, and at the top of it, that is the round ligament
Of the liver?
of the liver. And the round ligament of the liver in the fetus is used to be what? The umbilical vein.
Okay, I understand, thank you.
So the umbilicus is here, you go lateral to that. You can do it here, you can do it here, you can do it here, you can do it here. Now, when you make your cut, there is a little difference in terms of your cut when you are dealing with a male or when you are dealing with what? With the female. Okay? Now, in the female, the cut is what? Okay, the cut is straight. Okay, the cut is what? It's straight through the linear. Why? Because there is no prepuce, there is no penis. So, in the male, okay, you have to go in a curve. First, you need to move the penis and the prepuce to the side, okay, and then you make your cut like that. Make sense? Just bear this in mind. They will mention this when you go to surgery, like there is a difference when you make the cut, males versus female. Now, when you are doing this, you need to be careful with this artery, external pudendal artery. Why then? This is a big artery, right? Why you need to be careful about the external pudendal artery?
Because it runs through
Because it's a major blood supply to
the
abdominal wall. Are we good? Are we good, guys?
Would it also be because the genital femoral nerve runs with the
The genitofemoral nerve runs with the vein, with the external pudendal vein. So if you want to find the genitofemoral vein, go to the superficial, go here, okay? Go to the superficial inguinal ring, you will find, if it's a male, you will find the spermatic cord. Out of that, you will find the external pudendal artery and the external pudendal vein. At the top of the vein, you will find the nerve. That nerve is the genitofemoral nerve, which provides sensation to the skin on the inguinal area over here. Okay? Now, let me finish with one thing. I want you to understand it. Then next time you can go through the internal abdomen and the location of all the organs and the structures. Now, I want you to have a distinct understanding of what is vaginal ring, what is deep inguinal ring, and what is superficial inguinal ring, okay? We covered the inguinal canal and we said it is just a space, right? And we said we covered the deep inguinal ring and the superficial inguinal ring. Correct? Now, where the vaginal ring fits here? Like, what is it? So let me go back. Okay, let me go back to these layers. Okay? Let us focus on the last two inner layers, which is the peritoneum and the transversalis fascia. Okay? It is very easy to visualize this. Okay? So, we are inside the abdomen, okay? And we have the peritoneum lining the inside of the abdomen, right? And just outer to that is what? Is the transversalis fascia, right? Now, let us start with the transversalis fascia. Okay? Now, there is a natural opening there. Okay, the transversalis fascia is going to come from both sides and it will going to invaginate inside. Okay? This will create the deep inguinal ring. Okay? Now, this layer is the transversalis fascia, but you understand that there is a layer deeper to this, which is what? The peritoneum, right? The peritoneum will come and it will do the same. So the peritoneum, when it do that, it will create the vaginal ring. The transversalis fascia, when it dips there, it creates what? The deep inguinal ring. So when you open the abdomen and you are looking from the inside, can you see the deep inguinal ring?
No.
You can't. Actually, you are seeing what? The vaginal ring. If you want to see the deep inguinal ring, you need to cut the vaginal ring. You need to cut the peritoneum to be able to see what? The deep inguinal ring. So, the deep inguinal ring is formed by the transversalis fascia. The vaginal ring is formed by the peritoneum. Are we good? Now, when these two layers come out through the superficial inguinal ring, okay? Remember, they go inside and they go all the way to the outside, okay? The peritoneum will form the vaginal tunic. We change the name, okay? From peritoneum, it is peritoneum inside the abdomen, okay? Here it is already outside the abdomen, right? We don't call it peritoneum anymore, although it is the same peritoneum that it is inside. Down here we call it vaginal tunic. So the vaginal tunic actually it is what? It's peritoneum. The transversalis, we call it transversalis fascia when it is inside the abdomen because it is transverse abdominis muscle, right? On the outside, we don't call it transversalis fascia. We call it spermatic fascia. So now you have the understanding that what? The vaginal tunic is the peritoneum, right? And the spermatic fascia is what? Is the transversalis fascia, okay? And the transversalis will form what? The deep inguinal ring, and the peritoneum will form what? The vaginal ring. Now, all the structures that go through the vaginal ring, they have to go to the testes. They don't go anywhere else. So literally, these are the structures that form the spermatic cord, which are the vas deferens, it is artery, it is vein, it is nerve, it's lymphatic, testicular artery, testicular vein. All the components of the spermatic cord, they have to go through what? The vaginal ring. All the structure that go through the vaginal ring, they have to go to the testes. All the way down there in the scrotum. Now, what goes through the deep inguinal ring is what? You have external pudendal artery, external pudendal vein, and cremaster muscle. So, the external pudendals and the cremaster muscles, they go through the vaginal ring? No. They go through what? The deep inguinal ring. What goes through the vaginal ring is the component of what? Of the spermatic cord, right? Now, we said the peritoneum, okay, here we don't call it peritoneum, we call it what?
Vaginal tunic.
Vaginal tunic. So, if you cut the vaginal tunic, you are cutting the peritoneum, right? So, when you are doing castration, if you cut the vaginal tunic, okay, they call that open castration because you open the peritoneum. If you did the castration while the vaginal tunic is intact, okay, you didn't cut through, it is what? It's a closed castration. The open castration, okay, you see everything and you see what you are doing, but you run the possibility for what? Because you are opening the peritoneum. You are making a cut through the peritoneum, you run the risk for peritonitis. Okay? In closed, you don't run that risk. So most of veterinarians, they do what? The closed castration. They don't want to run the risk for what? Peritonitis. Why? Because the vaginal tunic is the extension of the peritoneum to the outside. The transversalis fascia will become what? The spermatic fascia. I want you to have that understanding. What passes through the vaginal ring, everything that are going to the testicles, those are the components of the spermatic cord. What runs through the deep inguinal ring?
Cremaster muscle.
Cremaster muscle, external pudendal artery and vein, genitofemoral nerve, and the spermatic cord itself, right?
Oh,
Right?
no.
Again. It is just, if you visualize it, it makes sense. This is the transversalis fascia, okay? It's creating the deep inguinal ring. Okay? You have external pudendal artery, vein, and genitofemoral nerve, and cremaster muscle are going through here. Then you have the peritoneum coming and go through here with all the structure that is forming the spermatic cord, right? So actually, through the deep inguinal ring, you have what? External pudendal artery, vein, and genitofemoral, and also this, right? Okay, because this is what? It's the spermatic cord. So it is going through the deep inguinal ring itself. The whole thing, the whole spermatic cord. Make sense?
Mm-hmm.
You good?
Is there like some branching with that goes?
There is no branching. Okay? That is the vaginal tunic surrounding everything. We call it spermatic cord. Okay? They need to go to the testing. Branch to go where? To do what? They have nothing to do with any other structure except
Spermatogenesis.
the testicles. Testicular artery, testicular vein, testicular lymphatic, the vas deferens artery and vein and lymphatic. So they don't go anywhere else. They have to go to the testes. Yes.
So it would run, the spermatic cord would first run through the deep inguinal ring, then into the vaginal ring. Do I have that? right? Or no?
The spermatic cord itself, it forms, the deflection is forming the vaginal ring.
Okay,
Make sense? Again, guys,
I think so.
again. Let us start with the transversalis fascia. There is a natural space. Go there and it will dips inside there, creating what? The deep inguinal ring. Okay? We have cremaster muscle is going to come and run through there. External pudendal artery will come and run through there. External pudendal vein will come and run through there. Genitofemoral nerve will come and run through there. But still, we have another layer deep to that, which is the peritoneum, right? So it will come and run through there. And everything that going to the testicle will go through here. The peritoneum, okay, at this level here, okay, creating what? The vaginal ring. So the vaginal ring is what? Is the peritoneum covering the deep inguinal ring. And everything that goes through here, we said, it's a component of the spermatic cord.
Okay.
We good? You good? Okay. I think this is enough for one day. So next time we're going to cover the GI from the esophagus